Our next item is delegating and assigning to other team members. So as an RN, you're going to be responsible for delegating and assigning to the LPN, to an assistive personnel, and in some cases to another RN who might be floating to your unit or to your department. So there's a couple of things that we want to keep in mind when we have these type of questions to help us to best answer them and to ensure that we are delegating and assigning correctly. So first, let's talk about delegating or assigning to the LPN. I want you to think about age, acuity, and time. Just hang on to that thought for a second because we're going to circle back to it. I want to mention that the overarching idea with delegating to the LPN is one, keeping in mind their scope of practice, and two, making sure that we're giving them patients that are most stable. Stable, I hear that word all the time, and we use it all the time, but it's really important that we think about what that means. If we're saying that a patient is stable, what we are implying is that whatever is going on with that patient is predictable. So whatever they have happening with them, whatever's going on with them, it is predictable. You can predict the outcomes that are going to happen with that patient. If they're unstable, that means that whatever's going on with them, whatever's happening with them, you cannot clearly predict those outcomes. And if they're not a predictable patient, that's not somebody that you want to give away. You, the RN, want to keep that patient to ensure that you're monitoring them, you're treating them, you're assessing them until in fact they do become stable, and then you can give that to the LPN. Now, coming back to our age, acuity, and time. These are things that help us to best determine, or maybe better determine, who to give to the LPN. So as far as age is concerned, patients that are very old and very young, they have a higher potential to be unstable. So we want to pay attention to when the question and the answer options are telling us the age of the patient. If they're very young or very old, just keep that in mind. They might be a little bit less stable than somebody else. Acuity, of course, acuity and stability are the same. So if somebody is high acuity, that means that they're unstable, which means what? They're unpredictable. If somebody is low acuity, it means that they are stable, which means that they are predictable, and that's a safe patient. Now, time. Time means if you have a time factor in that answer option, pay attention to it. We don't want to give patients away that are new, that are fresh, because if you're a new patient and had something that's suddenly occurred, chances are you're not very stable. If the patient is 24 hours or less post-surgery, post-procedure, post-admission, then that's a new patient. We don't want to give them away to the LPN just yet. But if they're over 24 hours, they're a little bit more stable, much more likely that we can give them away to the LPN. So let's look at some questions together and look at how we delegate and assign to the LPN, the AP, and the float nurse. For this first item, we're going to look at delegating to the LPN. And when we're delegating to the LPN, we want to utilize the AAT tool. That's age, acuity, and time. And that helps us to look at each one of those patients and determine who is the best fit for the LPN. So remember that when we delegate to the LPN, we want to give them patients that are the most stable. Now, when I say stability, remember, high acuity means you're unstable. Low acuity means you are stable. So we want to give them patients that are low acuity, which means stable. And we also want to consider what the LPN scope of practice is. We have to give them patients that are within their scope of practice. So if we read the question, it says, when assigning clients on a medical surgical floor to a RN and a LPN, it is best for the charge nurse to assign which client to the LPN. A child with bacterial meningitis with recent seizures. B, an older adult client with pneumonia and viral meningitis. C, a female client in isolation with meningococcal meningitis. And D, a male client 1 day post-op after drainage of a brain abscess. So the question is just asking us which client we want to give to the LPN. So who are we going to give to the LPN? And it's telling us that we're assigning clients on the med-surg floor to an RN and to an LPN. So which one of these goes to the LPN? So we think about outcomes of our problem. Remember, LPNs get low acuity, stable patients within their scope, and we want to make sure that we're using our AAT tool. So let's look at our patients here and think about those outcomes. So a child with bacterial meningitis with recent seizures. Here we have an age factor. So here's a child, and we know that very old and very young may be less stable than others. Has bacterial meningitis and recent seizures. So this patient actually has a point that aligns to each one of our factors, our A, and our T. So bacterial meningitis is high acuity, unstable. Why? Because you can't predict the outcomes of that. We don't know what's going to happen with bacterial meningitis. The patient can have increased ICP, seizures, become septic, could be fatal. We can't predict which way that's going to go. So if you can't predict which way that's going to go for the patient, that's an unstable patient. And then recent seizures, that points to time. That means that these seizures have been happening recently. So A is not a good fit for the LPN. Now, B says an older adult client with pneumonia and viral meningitis. So here we have an older adult. Here's our age factor. Nothing about time, but we do, of course, have acuity. Acuity is going to be found by looking at what's going on with the patient. So pneumonia and viral meningitis, both of these are viral infections. Pneumonia is always going to be viral unless it's stated to be otherwise. So pneumonia and viral meningitis, those things are low acuity. They're low because we can predict the outcomes. We know how that's going to go. Think about viral infections. What do you do for a viral infection? Nothing, right? You let it run its course, you treat the symptoms, you keep the patient comfortable, but there's really nothing else that we do for that. And so viral infections are really predictable in that way. So this is a low acuity patient. Let's hang on to that. Now, C says a female client in isolation with meningococcal meningitis. So no age factor, no time factor, but we have acuity, right? We're always going to have that. Meningococcal meningitis. What type of meningitis is that? Bacterial, right? It's bacterial meningitis. Bacterial meningitis, just like we said with option A, is unstable. High acuity, we can't predict that. So we're going to get rid of C. D says a male client 1 day post-op after drainage of a brain abscess. So nothing about age, but we do have a time factor in here, 1 day post-op. And we said with our time factor, if they've had something go on within the last 24 hours, we want to pay close attention to that because that can make them a little bit less stable. And this client had a brain abscess drain. So what do we think about that as far as acuity? Predictable or not predictable? Definitely not predictable because we don't know what's going to happen now with this patient. Think about all of the outcomes that could happen. Increased ICP, seizures, infection. We don't know what's going to happen now with this client, and they're within 24 hours of this procedure. They're not stable. They're not predictable. So we're not going to give this client to the LPN. So the correct answer here is B. Out of all of our clients, B is the most stable client. APs or assistive personnels can do constant unchanged.